And we're live.
Good evening, everyone. My name is Kenneth Jones, and I serve as president of Amita Health St. Francis Hospital in Evanston. I want to welcome you to our presentation tonight, hosted by Second Baptist Church and Amita Health St. Francis. The webinar is entitled Bridging the Gaps, Black Health and the COVID-19 Vaccine. I want to ask Reverend Dr. Michael Neighbors, Senior Pastor of Second Baptist Church, to lead us in an opening prayer.
Thank you so much, Kenneth. And before I open with prayer, I want to say good evening also to all of our distinguished panelists. We're extremely grateful that you've taken time out of your very, very busy schedules as medical professionals and doctors to be with us tonight on this important occasion. Let us bow in prayer. Lord God, we are grateful for these moments together tonight. We pray that you would look down upon us and that you would bless us with a measure of your Holy Spirit, that you would bring us together of singleness of mind. We pray that you would give us acuity of tongue, clarity of mind, that as we discuss this pivotal issue of the times, that we might be able to lend insight, especially for our people and for our community. We thank you for the wonderful professionalism and the gifts that you have given to these amazing doctors tonight. We thank you for using them as instruments in your divine hands to be a source of health and healing for all of us. We pray that you would bless all of those who are on the line tonight, that you would also allow them to have and take away important lessons that they may be able to apply them as we move forward during this pandemic. This we pray in the name of Jesus. Amen.
Amen. Thank you, Reverend Neighbors. I will do a quick introduction of our panelists, starting with Dr. Nathaniel Johnson, PharmD at North Shore University Health System.
Hi, good evening, everyone. Thanks so much for having me. It's a pleasure to be here. I'm currently a pharmacist, a pharmacy resident at North Shore University Health System. I was actually born and raised in Evanston, and a lot of my family is still there. And it's a pleasure to be here. Thank you for having me.
Thank you. Next up, we have Dr. Riley Lloyd on staff at Amita Health St. Francis.
Dr. Riley Lloyd. I'm a gynecologist specializing in women's health and wellness. I've been practicing for 30 years in the Chicago area in Evanston. Thank you.
Thank you. Next, we have Dr. Richard Phillips, Regional Medical Director, Illinois Emergency Medical Specialist.
Hi, Kenneth. Thanks for having me here tonight. My name is Richard Phillips. As Kenneth said earlier, I am the Regional Medical Director for Illinois Emergency Medicine Specialists. I'm also the Medical Director for the Emergency Department at Amita Health Advent Medical Center, Glen Oaks. In addition to my administrative duties, I still have a full-time clinical practice in emergency medicine, and I just completed a shift a couple hours ago, and I'm looking forward to a vibrant discussion.
Thank you. And last but not least, we have Dr. Barrett Robertson, MD, MPH, at North Shore Medical Group.
Hi, my name is Barrett Robinson, and I'm one of the maternal fetal medicine physicians. So that's a subspecialty of OBGYN, meaning that I care for women who have high-risk pregnancies. Women can be high risk in their pregnancies for many different reasons. So my job is to help safeguard mother as well as baby. I'm also one of the associate site directors for the residency training program for several different students from both the University of Chicago as well as the Amita Health System. Glad to be here.
Very much. Just a couple of housekeeping items. If you have questions along the way, I ask you place your questions in the chat box, and towards the end of the presentation, I will read out some of those questions for the panelists. So let's go ahead and get started tonight. And once again, thank you everyone for joining us for this important topic tonight. So the first question is for Dr. Phillips. There's been a lot in the news related to COVID, the impact on COVID and the African-American community, the risk, mortality. Maybe if you can provide the audience just kind of a general overview of what you're seeing from an emergency room perspective and how COVID has really impacted Black and Brown communities.
Thanks for that question, Kenneth. COVID-19 is the disease caused by the novel coronavirus. I think at this point, we're all pretty familiar with the disease. COVID-19 mimics other viral illnesses in that it can cause fever, cough, difficulty breathing, and so forth. What makes COVID-19 unique is how sick it can make you. I'm sure we've heard it on TV and perhaps we've experienced it amongst our own family members. But I can tell you from the front lines that Black and Brown people and Black and Brown communities have been disproportionately harmed by this disease. This is the result not so much of genetics per se, but really a function of health and other social determinants that have worked against us. We have higher rates of hypertension and diabetes and obesity and heart disease that predispose those patients who do get COVID-19, the coronavirus, to having more serious outcomes. Now, the COVID-19 has a mortality rate of about 1.5% to 2%. And just to give the folks on this webinar an idea of what that means is that if there were 100 people on this webinar and everyone got COVID, about 2 people would die from the COVID. Now, that mortality rate is about 50% higher for those in the African-American community. So that mortality rate would be around 2 to 3%. And what that means is that there's an additional person who would die from COVID-19 just in our community because of our predisposing factors. Now, the death rate alone, I know we focus on that quite a bit, it doesn't really speak to those who might not die, but really get ill enough to require hospitalization. And that's something that we should talk about. The hospitalization rate for COVID-19 is approximately 15 to 20%. So again, taking this webinar, if all 100 people on this webinar were to get COVID-19, about 20 would require hospitalization, which is significant. Now, this hospitalization, it could vary. It can be anything from a 3-day stay in the hospital just for some supplemental oxygen, all the way to an ICU stay. And the reality is at this point, when you're going in, you don't know what your trajectory will be. The data has borne out that those patients who are older and who have comorbidities tend to fare worse. But I can tell you from my personal experience that the very first person with COVID-19 that I took care of was in early March, and it was an African-American man. And he was about 20 years old with no real significant problems. He was a little bigger and he had some asthma, but otherwise relatively healthy. Well, I can tell you, I admitted him in early March and he stayed in the hospital for 5 weeks, most of that time on a ventilator. And the reason I say all this, I want you to understand that even though he survived, he had significant morbidity that comes with the disease, and people need to fully appreciate that. I say that just so folks don't understand that COVID-19 is not just like the flu. Yes, 80% of the people who get the virus will be okay, but you simply do not know going in whether or not you'll be in that 80% or if you'll be in that 20% who will not. And that, if for no other reasons, is enough for you to get the vaccine if it's offered to you, to prevent serious illness and get immunized. I'm looking forward to a vibrant and vigorous debate amongst the panelists. Thank you very much.
Thank you very much, Dr. Phillips, for your insight as relates to the front line as an ED physician. We know you see the various circumstances in the community, and I want to thank you for your context. And you talked some about the vaccine, and I want to ask this next question of Dr. Nathaniel Johnson from a pharmacy perspective. And there's a lot of myths and rumors and questions that our community has related to the vaccine, the production of the vaccine, what the vaccine, some of the side effects of the vaccine, as well as the clinical trial. So maybe if you could provide the audience just some color commentary related to kind of your thoughts from a pharmacy perspective.
Yeah, certainly. Thanks so much for your question. So there's 2 trials, or there's 2 vaccines that were produced as a result of 2 trials. So the first vaccine is by Pfizer, and the second vaccine is by Moderna. They are both mRNA vaccines. And while mRNA technology isn't new, it's been studied for decades, the development of these vaccines did happen relatively quick, and that's because of the way that they're produced. So they're essentially made in a laboratory, and it's an mRNA, it's a protein, and in combination with that, there's lipids in the vaccine. There's also certain salts. So what happens is once the vaccine is administered, it triggers an immune response from our body. It contains a protein called a spike protein, and it contains that spike protein is from the COVID virus, but it's not the virus itself. It's a spike protein that's from the outside of the virus. And then what they did is they encapsulated that spike protein inside of a lipid coat, and that's essentially the vaccine mixed in with those salts and like the sugars and the other ingredients. And that's essentially what's in the vaccine. There's no other ingredients that are in that vaccine. And with regard to the trials, both trials were about 30,000 patients, and about 80% of those patients in each trial were white, and then about 9 or 10% were Black, and then about 4% were Asian in each trial, and then about less than 1% were like Pacific Islanders or Native American Indians. So both trials took place relatively quick, over a period of about 3 to 4 months. And the most common adverse effects in both trials was injection site pain, which is very common with vaccines. Those occurred at an occurrence rate of about 79 or 80%. And then the second most common adverse effects were fatigue and headache. But other than that, they were both relatively safe. The incidence of COVID disease in the Moderna trial was about, 11 patients out of 15,000 that received the vaccine contracted COVID virus. So it was about a 94-95% efficacy rate. And in the Pfizer trial, there are about 18,000 patients that received the vaccine, and 8 of those patients developed the coronavirus, which is also an efficacy rate of about 95%. So both vaccines proved to be very effective as well as relatively safe. Each adverse effect that I mentioned, such as injection site pain, fatigue and headache, those are all common with other vaccines as well, such as the influenza vaccination, as well as the pneumococcal vaccination. So both relatively safe. And yeah, I'm just excited to see this pandemic come to an end, and these vaccines are the key to getting there.
Thank you very much. There's a lot of discussion in our community related to the impact of the vaccine side effects as it relates to moms who are expecting, dads who are working on getting pregnant, the impact of the baby. So this next question is for Dr. Robinson. Can you provide some context related to the safety of the vaccine from a family planning perspective?
Yeah, be glad to. First and foremost, I'd like to say that when we talk about women who are pregnant, we know that if a woman is pregnant and contracts coronavirus, that she is more likely to miscarry, more likely to experience preterm labor and preterm delivery. We also know that from mom's perspective, if she gets coronavirus, then she will be more likely compared to women who are her same age and have her same medical conditions to require ICU admission. And also, unfortunately, more likely to require ventilation, meaning have a tube put down her throat and have a machine breathing for her. So there's something about pregnancy, and we've seen this in other infectious conditions like influenza, that causes women who become sick with certain viruses during pregnancy to fare even worse than they would if they were not pregnant. I'll just say that if a woman gets coronavirus while she's pregnant, it doesn't seem like there's any increased rate of birth defects. That's a question that I get sometimes. And with respect to whether or not stillbirth rate is higher, by stillbirth, I mean the baby dying before delivery inside of the woman's womb. It seems like the stillbirth rate is a little bit higher, but mainly for those patients who are gravely ill. So, if a pregnant woman gets coronavirus, but just has a cough or has a fever and doesn't require hospitalization, then in most instances we'd say she probably doesn't need any extra monitoring of the baby. But for those women who are gravely ill and who have sepsis, it does seem like the baby also is more likely to suffer a very poor outcome or fate. And then a lot of times individuals want to know, well, if a woman contracts coronavirus while she's pregnant, is the baby gonna be born with coronavirus? And it looks like about 1% to 2% of instances will the baby actually contract the virus through the placenta. Obviously, if the infection occurs near the time of delivery, we'd want for the mom to take multiple precautions to avoid the baby being exposed. And sometimes that even could mean separation of mom and baby, or avoiding of breastfeeding and instead pumping and things of that sort. Obviously, mom should have a mask on if she's around baby and she's recently been affected. Or I'm sorry, infected. So that's just the backdrop for coronavirus infection in pregnancy. So we know that coronavirus is not something that pregnant women do well with during their pregnant state. It's something that certainly can make them at much higher risk of complications. Now, as many people in the panel are aware, these two trials that were done dealing with mRNA vaccines, unfortunately, they excluded pregnant patients. And I say it unfortunately, but that's actually probably a good thing because we like to be extra cautious whenever we're dealing with something that's unknown and has the potential to harm a pregnant woman or an unborn baby. So what's nice is that they excluded patients, but what's unfortunate is that that means that we don't have direct information about whether or not the vaccine can help pregnant patients as much as it helped those non-pregnant individuals. We also don't know about the safety profile of mRNA vaccine technology. What I can tell you is that there's nothing about the technology that has raised any concerns in terms of giving it to a pregnant patient. Sometimes I'll get questions about, well, mRNA, this is, these are nucleic acids. Is this something that actually, incorporates itself into the genome of the individual? No, it does not. Okay. So the mRNA essentially is a way to form proteins. This does not go into the DNA of the mother cells or the baby cells. So from that perspective, we have zero concerns. It does not seem that pregnant women are going to be less likely to benefit from how effective it is at revving up your body's immune response and allowing you to squelch any sort of coronavirus infection. We're taking some of this from other viruses and vaccines like influenza, but again, it's also responding similarly in terms of the infectious profile and what we call the immunotolerance of pregnancy. So the fact that pregnant women are just more likely to fare worse than non-pregnant individuals. So I have this conversation with patients every day about, should I get the vaccine? I am pregnant, and is it safe for me? And first of all, I let them know that we do not have data specific to pregnancy. There were a total of about 35,000 individuals between the two different studies, the Pfizer and the Moderna, who got active vaccine. And out of those, we know of 12 incidental pregnancies. And by incidental pregnancies, the women thought that they weren't pregnant, so they enrolled, and then later they found out that they were pregnant. And we didn't have any bad outcomes, but that doesn't tell us anything, quite frankly. All right, so 12 individuals having fairly normal outcomes is not, to me, a reason to say, oh, you should definitely get this. But it's the fact that we have used mRNA vaccines for, over a decade in other areas of medicine. It's the fact that we didn't see anything about the side effect profile that we think would harm a pregnant individual or an unborn baby, so long as you are treating any sort of fevers. That gives us confidence that if a woman is pregnant and wants to try to avoid coronavirus, then the best thing to do is to make sure that you're following all of the precautions, right? So social distancing, as well as washing your hands, wearing a mask, and avoiding any sick individuals. Having said that, if you are in a field where you cannot do that, because I've got many patients who are teachers, many patients who are nurses or physicians that see me, then I tell them, I think that the vaccine is something that is probably safe, But if you are interested in getting more data on it, because we are hoping to include women in some of these trials, then I think that that is very reasonable as well. But if I were counseling my wife that were pregnant, or my sister that were pregnant, and she were being potentially exposed, I would say that I would encourage her to get the vaccine if she's eligible. And that is in line with the professional bodies like the American College of Obstetrics and Gynecology and the Society for Maternal Fetal Medicine.
Thank you very much. I'm going to ask a follow-up question. I do see a question in the chat box that's related to pregnancies, and the question is, can COVID vaccine affect women of childbearing ages, like negatively affect their chances to get pregnant?
Yeah, so we do not know, quite frankly. We know that, so that wasn't one of the outcomes in the trials, right? But the outcomes that they looked at over the course of roughly 3 months were symptomatic COVID infection. But we don't know whether or not it could potentially impact your likelihood of getting pregnant. I will tell you that when you talk about COVID, that COVID can certainly wreak havoc on multiple different organ systems. All right, so when we talk about getting COVID, everyone thinks about the lungs, obviously, because that's something that is required in order to exchange oxygen. But we know that COVID can also impact the heart. We know that COVID can impact the brain. It can impact your auditory system. We know that COVID has been associated, particularly when you're talking about really severe cases of COVID, it's been associated with things like lower sperm count as well. But this is just what happens when an individual is gravely ill, right? So you see a lot of different effects on numerous different organ systems. So I will tell you that we do not know whether or not the vaccine can negatively impact someone's fertility. There's nothing suggestive of that because individuals who get the vaccine are not being infected with COVID. Okay, I think that's one thing that is a common misconception. But I will say that we haven't looked at all of those different potential outcomes like, well, is it less likely that someone will conceive within a year after getting the vaccine? There's nothing from a biologic plausibility perspective that would lead us to believe that, but it's not a bad question to ask in the study.
Thank you very much. The next question is for Dr. Lloyd. We hear a lot about the social determinants of health and the risk factors of African American men and women in our communities that has a higher correlation to comorbid conditions and mortalities related to COVID. So from a practicing physician perspective, what types of medical conditions do you see that really impact the African American community, and how can we as a community live healthier lifestyles?
Excellent question, and thank you, Ken. So disparities that we face are cardiovascular disease, hypertensive disease, diabetes, which is an endocrine disease. And so when we look at why are Black people dying at a higher rate and getting sicker, and why do we have more comorbidities, there's a lot of reasons for that. There's social reasons, there's access reasons, there are nutritional reasons in terms of deserts. So the concept, though, is that your best health insurance is to be healthy. And when we look at the difference between groups that do well in the face of a pandemic and our group that has a higher impact, it is really not, as was spoken, it's not the genetics, it is the degree of sickness and illness within our community. And so wellness becomes a foundational address. How are you going to get to the highest point upstream to affect our community? It is to get our community well. Now, what does that look like? We all know about nutrition. We all know about exercise. What I'd like to address is just two pillars tonight that you could start tonight affecting. And again, This doesn't cure COVID. This is not a treatment for COVID. It is get well, and then and in the face of a pandemic, your outcomes are better. And so the two pillars that I would address tonight in terms of a wellness aspect is number one, sleep. So what happens with sleep? It is a critical component of wellness. Sleep is the time when the body regenerates, when the body recovers, when the immune system recovers, when the brain cleans itself out of pollutants. And as a result of that, a good night's sleep results in an improved immune system, which reduces the risk of sicknesses, and that's across the board. It improves cardiovascular function, a good night's sleep. And a good night's sleep also improves its cognitive function, which means that's a lower incidence of Alzheimer's or senility. So we all are familiar with patients who have Alzheimer's. So what are the big killers? Cardiovascular disease, cancer, and senility. That's for all humans. And of course, in our population, that just occurs at a higher rate. So get well looks, one of the components and pillars for being wellness is sleep. It's an essential part. And what does that look like? Typically, you need about 7 hours of sleep. And it doesn't make any difference if you're a night owl or an early bird. You still need those 7 hours, and they should be uninterrupted. What does that environment looks like? Well, wherever you sleep, the environment should be conditioned and consistent that when you walk into that environment, your body says, oh, it's time to sleep, so I can get a good night's sleep. So I wake up in the morning refreshed and capable of addressing the day in any kind of environment that I'm being stressed about. And that means the room is dark, the room is cool, and cool means around 65 degrees. And trust me, I like my rooms warm during the day, but at night it needs to be cool. And that may seem cold, but under the covers, you actually get a better night's sleep in a cool room, a dark room. The other thing, it means it needs to be quiet. So, if you live next to a train station where trains are going all night long, then you have to get earplugs. It just needs to be quiet. So you try and do everything to make it quiet. And the big component, which we all have problems with, is it needs to be electronic free. So that means get the TV out of the bedroom and don't look at TV when you go to bed. If you want to look at TV, go outside the bedroom, because your brain needs to go into the bedroom and say, it's time to go to sleep. And it needs to be consistent. So you go to bed and you wake up routinely. And that means on the weekends, like, oh, it's time to sleep in on the weekends. No, not really if you're looking for wellness. Now, if you're looking for an extra couple hours of sleep because you stayed up late all during the week and you're trying to recover, it'll feel better, but it's not wellness. It doesn't make you healthier. It doesn't improve your immune system. It doesn't reduce your risk of Alzheimer's. It doesn't reduce your risk of hypertensive disease or impact hypertensive disease. So if you have it, that the therapies are more effective and you may not need as many medications. So sleep is a pillar of wellness. So what can you do tonight? You can get a good night's sleep. What does it take to do that? Those 4 or 5 things I just talked about. And yeah, it's a big argument getting a TV out of the bedroom, but at the end of the day, that is an important aspect. The other thing is, and I'm addressing things that you can just do starting tonight. I'm not addressing the big picture of nutrition and exercise and those kind of components or the disparities that our community suffers in terms of inequality of access and all those other components. The other thing you can do nutritionally is you take vitamin D. Now you hear a lot about vitamin D because they say vitamin D has an impact on COVID, and they have all these studies that reflect that. But actually the literature on vitamin D goes back 30 years in terms of the wellness environment, in terms of the data and the evidence in wellness. It is not just a vitamin, it is also categorized as a hormone. Vitamin D plays a role in many cellular reactions throughout your whole body that it's an essential component of. So vitamin D and when I mean vitamin D, I mean D as in dog. And so vitamin D is a very important vitamin for wellness. And now that we're in a global pandemic, you're hearing more about that, but that's not new, okay? And so what does vitamin D look like? Well, you can measure your level of vitamin D. A lot of people say, just take some vitamin D, take 1,000, take 5,000, take 10,000. Well, the real truth is that vitamin D can be measured. It's a simple blood test, And your range optimally should be between 50 and 90. Your range should be between 50 and 90. So if it's less than 50, it's too little. And actually vitamin D can get to toxic levels. It can get to be too high. So if you get above 90, then you want to start cutting back. The maintenance dose, typically this far north of the equator for vitamin D, is about 5,000 international units a day. If you're less than 50 or down in the 30 range, you want to boost that vitamin D levels up so you can actually take 10,000. These are daily doses. This is not the prescription weekly dose that I'm describing. I'm describing the daily dose because I believe that that's a better method of delivery. But the bottom line is get vitamin D and get your ranges between 50 and 100. So those two components are things you can start doing immediately to improve the wellness picture, with one of the most major pictures is getting a good night's sleep.
Thank you, Dr. Lloyd. A lot to learn as it relates to what we can do on a daily basis that really has an impact on our general health, which has a direct tie-in to the relationship of COVID-19 in our community. My next question is for Reverend Neighbors. As a faith leader in Evanston, leader of Second Baptist, NAACP, our community really listens to our community leaders as it relates to health, wellness, being in a pandemic, and as well as vaccines. So my question is related to the role of community leadership in times of challenges as it relates to healthcare, access to healthcare, the vaccine. What are your general comments for the group, and how can our faith leaders and our community leaders help to spread the word around health and wellness?
Kenneth, thank you for that question, which is a sobering question and almost demands a sort of analytical kind of response in several different areas. Because number one, that's a great general question, but then you're also asking it during a time of a pandemic. You're asking it at a time of a great unusual reality that our people are facing, and particularly people of color. So we're talking about the gap right now with regard to the vaccines. But in terms of our community leaders reaching our congregations and our constituents, one of the great challenges that we have, of course, is the gap that we call the digital divide. We have particular issues in terms of reaching large segments of our population. And generally speaking, those are the folks that may be most vulnerable to COVID-19. So we stop and think about, we've been doing live stream for most of our congregations in Evanston now for about a year. But the reality is there are a lot of our folks who are not live stream because they don't have access to information technology. So we have seniors who are still listening into our worship services on the telephone, right? The only way that we're able to reach a large number of our folks is through the telephone. And that's not just true for houses of worship, but it's true for community organizations as well, like the NAACP. We have folks who are on our executive committee who are just now learning about Zoom. And we've been in it for a year. We've been doing Zoom for a year, but God bless her. I'm going to mention Sister Bridges because she's 96 years old. Sister Bridges just became familiar with Zoom about a month ago. And she had a grandson that finally decided, you can't just continue to listen in on the phone. You need to be on Zoom. And so he's there with her every time we have a gathering now. So when you talk about the influence of community leaders, you're spot on. But the challenge is in this time of digital divide, where we are not as closely acclimated to the folks that we serve as we've been in the past. So one of the things that I would say that one of the great challenges we have is trying to create opportunities for every single house of worship and every single community organization to be able to teach their folks about the importance of computers. And then the second part of that is, depending on what area our folks are living in, we have to make sure that they have router capacity as well. So you all know that there are some parts in our community that have greater access to 24-hour service than there are others in terms of the internet. We live, for instance, in the 8th Ward, and I have a son who's in the high school. And just about every day, at some point or another, his internet capacity goes out because it's a part of the neighborhood that we live in. So we have to improve that as well. I think that by putting solid information into the hands of our leaders about how to become more creative and more resilient in terms of the digital divide and diminishing that is going to be helpful for healthcare as well. I think another point that that I want to bring up, Kenneth, and we didn't bring any psychologists into the room tonight, but I do want to say we have a psychologist at Second Baptist, Dr. Henry Perkins, who's at Northwestern University, who has said from the time that I met him that one of the greatest problems that Black people have, whether we agree with this or not, is really that we are born Black, that being born Black creates a stress that is uncommon and not natural among other people, that we are introduced to the reality of stress from the time that we're babies. And then we get older and all of that, and the stress is compiled. And all of us, of course, you being professionals, we find ways to handle and deal with that stress, but not everybody does it well. And as a result of that, that's another factor with regard to this whole COVID-19 issue. And Kenneth, I'm proud of the fact that you at St. Francis put out a tremendous community survey a couple of years ago that determined the number one healthcare concern that everybody on the North Shore has is mental health. That's a primary issue. So we're dealing not only with the biological reality of having pre-existing conditions that make us more vulnerable to COVID-19, but we're also dealing with the mental health issue as well. So my response to your question is community leaders and Black pastors have to be inundated with that information so that we can figure out, along with hospitals like St. Francis and Evanston North Shore, how can we develop strategies then to create education information for our constituents, so that we're not just up on Sunday morning preaching about Jesus and how Jesus will save you, but we're also up on Sunday morning preaching about how we can sleep well, take vitamin D, and do all of those necessary things like exercise and everything that you all have been talking about as well. That's just as important in a message on Sunday morning as the gospel is important. So we need you all to help us figure out how we can develop strategies of education to take into our congregations and into our communities to make a difference, especially with regard to COVID-19 and vaccines.
Thank you very much, Reverend Neighbors. I want to address a couple of topics that are in the chat box. And the first one is really related to the availability of the COVID vaccine. And for those who have watched the news, you know that the supply of the vaccine at this current time is very limited. Most organizations are really working through the 1A category, which are essential workers and healthcare workers, and down to the 1B staff, who are really essential workers, teachers, frontline essential workers, et cetera, as well as our seniors, who are the most vulnerable. One of the comments and questions in the chat box is related to if you live in the city of Evanston, how do you get access to the vaccine? And there is a contact form on the City of Evanston website that I encourage everyone who lives in the city of Evanston to complete. I talked to Ike Agbo, who is the director of the Department of Health in Evanston today. He's also on our incident command calls every Friday. And they're working from the older ages down based on vaccine availability. And so he asked everyone to really have patience, because supply is very low right now. And currently supply really exceeds the current demand. But he anticipates that over the next 3 weeks, the city of Evanston will have more vaccination to be able to distribute. He also encourages everyone to look at CVS, Walgreens, Joasco as being options, although they're having the same challenges as it relates to access to the vaccine inequalities as it relates to the number of people in our community that need to be vaccinated. So hope is out there. It will improve, but currently vaccines are very limited as of current date. I will go through the chat box and kind of go through and ask a few more questions, answer a few more questions. The next question is related to a general health question for Dr. Lloyd or Dr. Robinson. Studies have shown that Black women have a higher maternal mortality rate than other minorities. What are the solutions to combat this statistic?
Dr. Robinson.
Yeah, so I'd be glad to answer this. And actually, this is one of those topics which could probably take up an hour-long webinar in and of itself. But I'd say there are three different factors that probably contribute to this. One is from a comorbidity perspective, meaning, unfortunately, Black women tend to have higher rates of things like obesity, diabetes, hypertension. 1 in 2 women are obese. And this is something that certainly impacts risk profiles during the reproductive ages as well, so childbearing ages. 2, I'll say access is an issue, and oftentimes that's due to social determinants of health, right? So if you live in an area where you are not able to see a physician, or where there are not many physicians who practice, or if your insurance is not viewed as favorable or attractive, then it may take you a much longer time to get an appointment. You may not find out that you're pregnant until you're, midway through the 2nd trimester or close to the 3rd trimester. So we certainly have to improve things like access. We need to make sure that social determinants of health like food insecurity, housing insecurity, transportation insecurity, all of those things are addressed. And unfortunately, we know that those are disproportionate to individuals within the African American community. So it's a much bigger problem. It's not just something that a physician can easily write a prescription out for. I think we need to change the way that we are distributing resources in this country. And then thirdly, I'll say there's racism. There's implicit bias, there's also explicit bias. And so even when Black women are able to get into healthcare systems and see physicians or nurses or nurse midwives, unfortunately, they are often not taken as seriously, or their concerns are brushed to the side in ways that white women would not be. And so I think that is causing African-American women to also suffer disproportionately with respect to their mortality rate. And it's hard to kind of measure precisely mortality when you're just talking about one hospital or even one community. But the proxy is what we call severe maternal morbidity, which means, for example, women being admitted to the ICU where they almost die, or women requiring a blood transfusion because they lost so much blood, or women having extra fluid in their lungs that requires them to go to the ICU or become ventilated, or women having renal failure, women having a stroke, women having seizures, things that should not happen to a woman who is 30 years old or 35 years old or 40 years old or 20 years old. These are things that push them right to the edge of death. And so we really need to focus on making sure that hospitals are doing a better job of, one, trying to address social determinants of health. So get patients, the ability to make it to appointments, try to get them better means of food and nutrition, having them meet with nutritional counselors, trying to make sure that we are allowing for them to be in conditions that are going to optimize their health. 2, when they're in the hospital, when they're in their prenatal visits, we need to listen to them. We need to take their concerns seriously, knowing that they are at much higher risk of poor outcomes. And then 3, we need to address racism. And so that means making sure that white individuals. And, unfortunately, there's even implicit bias from African-American physicians towards our own people, right? This is called internalized racism. So we need to make sure that we are kind of retraining ourselves to make sure that we are being as egalitarian as possible, and essentially making sure that we are treating people in a just and equitable manner. So I would say those are kind of the three big things that we need to do as a nation in order to try to reverse this very disturbing trend of maternal mortality for African Americans. It's about 4 times that of non-Hispanic whites.
If I can, I'd like to add to that in the sense that the last 4 years have set us back dramatically. And although there's been a change of administration, that's not the promised land. We hope, I don't have a crystal ball, but that damage is not going to be repaired overnight or in the next few years. It's going to be a long-term repair. And I think what helps our community is when we're better neighbors. And so I think when it comes to that aspect, the disparity is not going to go away. We are going to have to do things to be healthier, but that digital divide that Reverend talked about, and the things that everyone's mentioned tonight, are going to require that as a community, we help each other out to a much higher degree. When you look back historically, when Blacks were thriving and there was less disparity, it was actually, when they were more segregated and they had to work together to do things together. And they didn't have a lot of money, but still they had thriving, successful communities with the amount of money that was within that community, because everybody took care of each other. And that's going to be another important focus in terms of health, is that we need to help each other. Depression and mental health is a major issue. And in our community, we tend to run away from it and get embarrassed by it. And we're going to have to reach out more and face those demons and bring people in and support each other. Access is a big deal. And so when there's a good physician, we as neighbors have to get each other to those people. And through that neighborly action that, we're going to have to be called to a much higher level. And we can't turn our backs on our neighbors like we used to, as we've done recently. So I think that's going to be a big important component of wellness and getting and addressing the disparities within our community on a health fashion, not just a social fashion, but on a health fashion.
Thank you very much, Drs. Robinson and Lloyd. My next question is related to, it says, for those who have contracted the coronavirus and have received monoclonal antibodies in the hospital, the CDC says wait 90 days before a vaccine. Is that true for everyone who has contracted coronavirus? Can you restate and explain why? We don't have an ID physician on the call, but would anyone like to try that question?
I can speak to that, Kenneth. The reality is the body's natural response to the coronavirus usually confers immunity for about 90 days or 3 months. That's the working knowledge right now. So if you were infected with the virus, you do have some degree of immunity just naturally. We're telling folks that if you do have the virus actively, you should wait 14 days before taking the vaccine. Just wait that entire period of time before you get vaccinated. This is also a supply issue as well. There's limited supply of the vaccine. So the reality is, if you're immune because of your own body's response, you may not need it in the near future. And with the limited supply, they want to go to folks who don't have the virus actively.
Thank you very much.
And Kenneth, if I could just go to speak directly about the monoclonal antibodies, that those medications are only given to those who will have the virus as well. So they have that same 90 days of immunity.
Thank you. The next question is related to Black people with cancer and who are taking medications that's treating cancer. Does anyone have any information on if there were cancer patients in the trials and any impacts from a COVID perspective? That was one of the questions. If not, we can follow back up with a response to that.
Yeah, I can speak to whether or not there were patients in the trials who had cancer. So there are actually no patients in either trial that had cancer, unfortunately. So that's data that we don't have.
Okay, thank you very much. The next question is related
Hey,
to.
Kenneth, I just want to piggyback on that answer. I think it's important to note that while we don't have any information on what the vaccine will do in those with cancer, we do have information on what COVID does with those with cancer. Cancer is inherently a hypermetabolic state. So getting COVID-19 while being immunosuppressed but while undergoing treatment for cancer can be devastating. So I don't believe cancer is a disqualifying factor in getting the vaccine. And if offered it and your doctor says that you should get it, you should go ahead and get vaccinated.
Thank you very much. The next question is, how long does the vaccine last, and how long are you protected after receiving the second shot?
We don't know. It's a new virus. It's a new vaccine. Sorry, but we don't know. We're tracking those, the vaccine now. We're checking antibodies on people and seeing how long their immunity is lasting. So if you just look at when the vaccines were administered in large doses, we're out 5 months. So far, 5 months, you're good. But to answer that question, the answer is we don't know.
And just to piggyback on that, we don't know how it will react to the variants that are coming about now from South Africa and from the UK. We speculate that there should be good immunity with the vaccine, but the reality is we just don't know. More to come.
Thank you very much. My next question is related to an emergency room question. So Dr. Phillips might want to take this one on. So how do we acknowledge the implicit bias in the ED during COVID-19 as it relates to African-American patients?
I think it's important to understand that this implicit bias existed before COVID-19 and it's going to exist after COVID-19. And it's present. I think the first thing we do is acknowledge it. Much like the vaccine hesitancy that exists in our community, it's important that we first acknowledge why it's there. And that implicit bias is there and we have to acknowledge it. And when you see it, you speak to it. But you speak to it in a respectful manner so that people aren't taken aback by it, or they are willing to hear what you have to say. I will say that what I'm doing for my own group is that we're actually having a trainer come to speak to our group about implicit bias in April. So this is something that we're actively working on throughout all of Amita Health. It's something that I encourage all physician practices to take on because it's important.
Thank you very much. I'll answer the next question. It's related to after our patients in the community complete the vaccination process, how can you all help? I know both systems have volunteers where we're soliciting volunteers to really help with our vaccination administration process for those who are interested in participating in that. The health department, as well as our local federally qualified health centers are also seeking volunteers. I think education is critically important. As this session, I did want to remind everyone this session is being recorded, and so we will be able to stream this for those who are not available in real time to watch this session. But it's really making sure that you're having conversations with your physician, making sure that you're looking out for your neighbor, making sure that if there's someone in your community that is high risk, that you're encouraging them to take the vaccine and providing resources for those who are in need. And so I would reach out to your local community service organizations, social organizations, health department, hospitals, primary care physicians, just to better find out how you can help and how you can provide resources for those who are in need. The next question is were the vaccines developed by an African-American physician?
So I can answer this one. As Dr. Anthony Fauci mentioned back in December, Dr. Kizzmekia Corbett, who's a PhD, is the NIH's lead vaccine head of research for coronavirus. So along with Dr. Barney Graham, those were the two scientists that are most directly responsible for the mRNA vaccine being produced and created so quickly. And this is a Black woman, so she's someone that we should celebrate without a doubt.
Thank you very much. We're at the 1 hour mark, and I want to maybe turn things over to our panelists for final comments. And I don't see any more cues or questions.
There's one more.
A little more? Okay.
There's one more. It says, concerning children, how are they being affected physically, spiritually, and mentally? Their worlds are altered forever as ours are. They can't go to school, to church, play dates, visiting relatives, the list goes on and on. What can you all share to help us explain this in a way to children that makes sense?
Eddie, that's a great question. That sounds like what Barrett said about one of his questions. That could be an independent webinar all by itself, that's for sure.
Yeah, so this is a big one. There's a lot to unpack here. I would reference a CNN Sesame Street documentary, not documentary, special that came on. It was a 2-hour-long special. You should be able to find it in one of CNN's archived websites, essentially, that tried to explain COVID to young children. I think the ages from 3 and up, essentially. But we know that this is, you're going to hear this and you've heard it, an unprecedented time. And so none of us, when we were children, were put through anything like this. So I think first and foremost, we need to acknowledge that however children are dealing with this is an appropriate way for them to deal with it, okay? Their perspective is one which is going to be authentic, and you're right, their reality has been shattered in many ways. So I think that acknowledging that and supporting them is very important. I also think that it is very reasonable, just as the AAP, the American Academy of Pediatrics says, to try to do everything possible to get students back in school. And that's something that I think is happening more and more often now because of some very compelling data that's come out of multiple different countries that have kept school going, showing that transmission within schools when masking and social distancing and hand washing is taking place is extremely low, and that children, particularly those 10 and under, do not seem to either get infected or transmit the virus nearly as efficiently as either older children or adults. And so I think that it is very reasonable for you as a parent to try to get your child back into school in an effort to try to recreate some semblance of normalcy. I also think it's reasonable as a parent, if you are very afraid of coronavirus, as we all should be, to say, you know what, I'm gonna have my child stay home with me and continue doing virtual learning. So there's no right answer to this. A lot of individuals want to know, can children get the vaccine? So children have not been included in trials yet. There is some thought that they will be at some point within the coming year. The first step, so the Pfizer vaccine did go down to age 16. So technically some children, meaning teenagers, were included. And the next thought is that those 12 to 15 are probably going to be among the next group of individuals that are included in vaccine studies. In terms of younger than that, it's unclear. And I can certainly say that as a maternal fetal medicine physician, a lot of women ask me, can babies get the vaccine? There are no plans for babies to get the vaccine. I can tell you that being an infant seems like it is something that is an independent predictor of poor outcome for COVID. But the immune response, I would say probably not until 6 months of age would there even be any consideration to giving a child a vaccine of this sort. There's just a lot that we don't know about it in children. As mentioned, this is a novel approach. So yes, as a parent, I would say listen to your child, talk to them about what's going on, hear them, and then try to make the best decision for your household as to whether or not having your child back in school or continuing remote learning is a decision that you're comfortable with.
Thank you very much. Oh, go ahead, Dr. Lloyd.
Barry was actually right when he was saying how we've never lived through this before. Our kids haven't lived through this before, and our experience and as adults, we call on our experience, what we went through, our tough times as kids, and we pull that as a foundation for how we address this pandemic and get through it. But I think it's important, like Barry was saying, is that that's really not relevant to the kids. This is something completely different. And so when we talk about biases, like the biases against Blacks, we have to be careful. And I think it's important that we recognize that our bias in terms of our personal experience as adults is not relevant to these children today. And so the therapy for to get around our own personal bias as it directs to our own children, because we'll say, no, I went through that, so you should be able to handle this. What's wrong, That's not relevant to these kids today, because this is something completely new and we're unequipped to deal with these children right now. Except we have the greatest tool of all, and that is sitting, listening, being tolerant, and loving our kids unconditionally. So the treatment for these children right now is a ton of love. And when you get tired and the kids are running around because they've been in the house all day and you've been with them, which is brand new, and you get upset, you've got to stop, take a breath as the adult and say, okay, what's the loving thing to do for my child? And that's really the only effective tool that we have currently that has been well proven to be effective.
Thank you very much.
Kenneth, let me say two quick things. One of our ministers just shared with us that the Second Baptist CYT, Children, Youth, and Teens Ministry, will be having a webinar on COVID-19 for our children on April 17th. So that's one of those pieces that we're talking about in terms of trying to reach and educate our community. But I know it's late, but the last thing I wanted to ask you all, because I think our audience would be very interested in hearing the answer, as amazing African-American doctors as you are and healthcare experts, the question has to go out. Have you all received your vaccines?
Yes, I received my vaccine. Both of them.
Yeah, okay.
Well, second in line.
Yeah.
Yes, I've received both of my shots.
I've not received mine yet, but I plan to hopefully within the next month or so.
And yes, I've received both of my shots as well.
Okay, thank you all. That's certainly leading by example. So that's why I ask the question, especially for those of you who are working with patients and are on the front lines. Yeah.
So I have two more questions that are really pharmacy related questions. The first is, are there any over-the-counter medications that will have an adverse reaction if you take the vaccine? And the second is, are people with severe allergies who use EpiPens discouraged from getting the vaccine?
So to answer the first question, there's currently no known over-the-counter medications that interact with the vaccine. And the second question was, is there any discouragement to receiving the vaccine if you have hypersensitivity reactions? If you have an
if you use the an EpiPen.
Yeah, so no, there's currently no known information about that as well. There were a very few number of hypersensitivity reactions to the COVID vaccine in the trials, but a very low number, about 1.1 to 1.5%. And those reactions where people actually had a hypersensitivity reaction, such as like anaphylaxis, like swelling of the throat, but those were very low.
Thank you very much.
In regards to that, could I ask Dr. Johnson? One of the things that's going around, I think that they may be referring to, is that if you take an NSAID, it may reduce the effectiveness of the vaccine. Is that true?
I haven't seen any information about that, but medications like NSAIDs, they can be used to help with some of the potential side effects of the vaccine, such as headache or muscle pain or muscle aches.
I think it's worth noting that if you have had an allergy to a prior vaccination, it's possible you could have a reaction to the diluent within the vaccine. So you need to make sure your provider is aware of that so that they can take appropriate precautions. Most of the reactions that people have had with regards to anaphylaxis have happened within 30 minutes of taking the vaccine. So they may simply monitor you for a slightly longer period of time.
Thank you very much. I want to turn things over to our panelists for final comments. I want to thank everyone for joining us tonight. I want to really thank Reverend Neighbors and the Second Baptist team, as well as our panelists, for allowing us to come together to share our words. And so, starting with Dr. Phillips, any parting words, and we can just go around the table and then conclude the event for the night.
No, Kenneth. Pastor Neighbors, Kenneth, thank you for inviting me to this forum. It's been great. I learned a lot. I think it's hopefully this information will get dispersed into our community and we can relieve some of that vaccine hesitancy. I'm looking forward to seeing a better day in the future. And I think what we can give people is hope. And that's what the vaccine is. It's hope. Thank you.
All right, Dr. Robinson.
Yeah, so, I think that hope is certainly on its way. I recall probably about 3 to 4 weeks ago finding out that only 1% of the population in the United States had been vaccinated, and earlier this week found out that we're up to 7%. So I think that we are doing a much better job, and I know that it can be frustrating. My wife, for example, every morning is on the computer searching for different places within Illinois and within Ohio where vaccines are available to try to take care of some of the elderly individuals that we know and love and are in our lives. And so, I would actually say, Pastor Neighbors, I'm not sure if this is something that Second Baptist has been involved with, but because of the digital divide and because it can be so hard to navigate these websites and the different distribution vehicles, it might be worthwhile to have a service set up to help seniors because you click on it one moment and then it's gone within 5 minutes. So if there was some way that we could, as a community, try to help seniors get registered for these vaccines, and it might even mean trying to help them get the transportation to go to some place that's an hour away that's not in Evanston, because it's really hard to find these, and when you find it you got to snatch it up. Maybe it's a database or something that has different members or interested individuals who know that they will receive the vaccine if they're able to get it. That might be a valuable service to the community.
Thank you, Barrett. We'll certainly follow up on that. Thank you.
Thank you. Dr. Johnson.
Yeah, so I just wanted to say it's been a pleasure to be a part of this panel. I learned a large amount of information, and I'm just really excited to see the pandemic come to an end. I'm just really hopeful for positive outcomes in the future.
And then Dr. Lohr, we do have a couple of questions, follow-up questions about other supplements that you would recommend to boost the immune system. And then do naps help if you don't get a good night's sleep? And then your parting comments.
No, naps don't help, unfortunately. In terms of helping the sleep cycle, they actually can interfere with that if you nap too long. It's not mean that you shouldn't take a nap, but again, it's consistency, and they don't give you that regenerative sleep and the repair that occurs during that time. In terms of other supplements, I would say, you go online and there's a lot of garbage out there. And it's a deeper discussion. When people say, can I take this supplement, that supplement? Well, the reality is you may not need that supplement. So, people grabbing, 20 or 30 supplements and they haven't assessed what their needs are. The big thing is eat healthy. If you eat healthy, most of the nutrients your body needs, you'll get from a good source of adequate nutrition. Vitamin D doesn't come from food. So that's one of the ones that don't. So that's why it's important to take as a supplement. So no, I wouldn't recommend any supplements without having talked to a patient or them seeing, someone to evaluate those needs. But online, be careful what you search for, because for every search you make, there'll be a million things and 99.9% of it's garbage. So it's very scary out there in the supplement world. So be careful, that's all. Vitamin D is not one of those. Take your vitamin D. And no, naps don't help. And the other piece is, you know, we do have hope. We have a light at the end of the tunnel. We've been at this for a year. We've been practicing things to be healthy for a year. And the goal is keep practicing them. I mean, you got practice in now. You got a year's worth of practice of wearing a mask, washing your hands, distancing. Don't give that up until you have a vaccine, until a lot of other people have a vaccine, and until the all clear, you know, signal has been given. And don't get relaxed because someone else got the vaccine or you got the vaccine. Keep practicing the things that we know work. And again, it's coming to an end. Hang in there, but don't give up on the tried and true simple things.
Thank you very much.
In your hands.
Reverend Neighbors, any parting thoughts? I'll let you conclude the event. I also want to say thank you all for joining us and turn things over to Reverend Neighbors for conclusion.
Kenneth, thank you for serving as an outstanding moderator tonight. We're grateful for the tremendous contributions that you've made to our community at Amita St. Francis, and to all of our panelists tonight. You all were really outstanding. I've been receiving texts from members throughout our discussion talking about how superlative the panel has been, information filled, and definitely inspiring at the same time. So we're really grateful for this, and we're looking forward to taking this and putting it on Vimeo, according to our IT specialists, and sharing it with other people as well. And Riley, you sort of stole my thunder a little bit. You said hang in there a little bit. You all talking about faith. I end every service, and some of you all are members the same way. So I'm going to end it tonight as well. Keep the faith, baby. Thank you.
Thank you very much.
Okay. Have a good night, everybody.
Thank you.
Thank you.
Okay.